Director, Conference of Legal Counsel, and 3 hearings under Health and Safety Code regarding patient safety report, disclosure summary report, and risk management report. Item 6.7, approval of the closed session minutes from the regular meeting in December. Those minutes were approved on a 5-0 vote.
So, okay.
And
Yeah,
Dr. Cole, there you go. And the last item 8, the medical staff credentialing under Health and Safety Code 32155, those recommendations were also approved on a 5-0 vote by the board.
Thank you so much. Any deletions or corrections to the posted agenda for the open session? Okay.
I wanted to correct the minutes from the last regular meeting because it has me listed as absent, but I was there. I had.
So that comes under the consent calendar.
Okay.
So this is for the agenda that's posted.
So Director Barnett, what you'll do is you'll ask to have those minutes pulled when we come to the consent agenda, and then we'll consider those separately.
Thank you.
Clarification though, Bob, it actually says you showed up at like 4:02. So it says absent, but then it says, if you look down just a few sections, it says you then showed up at 4:02.
Yeah, well, I just want to correct that I'm absent. That, of course, is a conflict with the 2 there, but
2-minute absence is what it has in the minutes. So
2
I'm
minutes.
not sure we really want to pull the minutes just to do that, but in any event,
All right.
right now we're on the posted agenda. And if there's no corrections, then we'll move on to audience input. And this is an opportunity for our public to make any kind of comment on something that is not on the agenda. And if you choose to make a comment or want to speak, you've got 3 minutes to present your item. And just to let you know, we cannot discuss it by the rules of the Brown Act. And also, if you're not here for the Zoom meeting, you can always submit your comments via email or in writing to our clerk of the board. So with that introduction, are there any comments from our audience? Okay. Okay.
Yeah, and so to make a comment, just to reiterate, you would use the raise hand function,
Okay.
which is located at the bottom of the toolbar under reactions, and that will alert the clerk to your interest in speaking.
Seeing no hands, hearing none from our audience or emails or written ones. Martina, have you gotten anything?
No, we have not received any written public comment and nothing from the employee associations either.
Okay. Is there anybody in the audience from the employee association that would like to speak? Okay, seeing nobody and hearing that there haven't been any written submissions by the Employees Association, we'll move on to item 13, which is the consent calendar. And these are items that are usually non-controversial. They are reports in general, and there is the opportunity for anybody from the board or the staff to pull any items on that consent calendar. So at this time, is there a correction to the minutes? Or Martina, do you know if those minutes need to be corrected?
Well, I don't believe Director Barnett was there for the actual roll call, but I do believe that the minutes reflect when he entered the meeting. So.
Okay, so Director Barnett, do you still want to pull the minutes?
No, that's good enough. It was a wild time with no power.
So you were in the dark, but you were present. Yeah.
Yes.
Okay. Again, are there any items that anybody would like to pull? Okay, hearing none, can I have a motion to accept the consent calendar as presented?
Move approval, please.
Can I have a second, please?
I'll
Second,
second.
Okay, I'll take Director Barnett. So I have a motion by Director Brown, a second by Director Barnett to accept the consent calendar as presented. A roll call vote.
Director Barnett,
aye.
Director Shamblin,
Yes.
Director McGeary,
Yes.
Director Brown,
Yes.
Director Wong.
Calendar has been approved. We'll move on to item 14, and these are items for board action. And our first item is 14.1, our corporate compliance work plan. And we have Jim Hook from the Fox Group to do that. So Jim, you're on.
Thank you, Chair Wong, and good evening, everyone. Tonight, we're presenting the corporate compliance plan, a work plan, which is a work plan that is developed every year and guides our compliance program through the year. And I understand there was a question about the role of the board in approving these work plans. So we did include a couple of slides here about the role of the board in compliance and where that comes from. And the three things you see here on that slide, like duty of care and oversight and decision-making, these are all things that come out of the California corporation law as responsibilities of the board. And this is really emphasized in the US sentencing guidelines, which also make a comment about the role of the board in a compliance program. And it includes much of what you see here, particularly making decisions in good faith, exercising due diligence, and asking questions. So that's the reason for the role of the board and excuse me, in the compliance program. As I mentioned, the work program, the work plan covers these 7 elements of an effective program, everything from policies and procedures and oversight to training, education, internal monitoring, and finally disciplinary guidelines. So we have an element for each one of those things, or more than one elements for each one of those elements, more than one activity, I should say. And next page. Okay, thank you, Martina. So the first element is policies and procedures. Basically, we look at policies that come up for review during the year, since all the policies and procedures are on a rotation for approval. And whatever comes up during the year, we will review and recommend any changes. And in addition, there are things that can come up related to policies and procedures outside of that normal rotation process. And so we'll also take a look at those and review and revise them as necessary. The second element of oversight is provided in part by the board, in part by the compliance committee. So each quarter, we provide you with 2 reports. An open session report and a closed session report. We ask for an evaluation of the compliance program by the board, and each 2 years, so this year we'll be doing this again, we do an evaluation of the compliance program using a tool that we have, so that we make sure we're covering all of the things that an effective and well-documented compliance program should cover. There's several activities under education and training, in particular, education and training of all new staff members, as well as annual training, an annual attestation of the code of conduct, and training delivered via HealthStream for both compliance and HIPAA. The HR department includes HIPAA and compliance in their values training that they put on. We would want to do an annual refresher or update for the board sometime during this year. And we'd also like to do a update for all directors, managers, and supervisors. We haven't done that for a couple of years now. Hopefully that could be in person. We also would like to do an annual update for the medical staff if they're still having general staff meetings. And then we do education through our articles in the Pace Setter, which we try to publish 6 to 9 articles a year covering privacy, compliance, information security. And these are actually a requirement of the HIPAA security rule to do periodic security awareness reminders for staff members. So this fulfills that particular requirement, along with things that the information technology department does. There's also a supplier code of conduct that should be distributed to all vendors annually that remind them about the compliance program at the hospital and what the expectations are for all vendors. Then we have our annual auditing and monitoring program. Most of these audits are things that go on year to year, and they're particular risk areas that it's easy to fall out of compliance with, or they are big risks. For instance, coding and billing is a constant risk. And although there's an outside coding organization now that's handling the coding, and they have been doing internal audits, that's one that we want to keep on our list. Same thing with rural health clinic consents and the Truckee Surgery Center medical records and billing audit, which is a requirement of their accreditation standards. So we have cut the list down to 9. I think last year we had 12. So there's some things that we don't feel we need to do anymore because they're being managed quite well and we're not seeing any problems in the audits. As far as response and investigation, of course, we follow up on all our hotline calls or any other contacts since we don't get very many hotline calls these days. And we have a requirement to submit an annual report of unauthorized disclosures that are reportable to HHS. That has to be in by the end of February this year. As far as enforcement and discipline, all the employees and medical staff and vendors are screened for any pre-existing exclusion from a government healthcare program, either by the federal government or state government. And then if we do get reports, we respond and investigate those things, and our policies provide for corrective action and disciplinary action in case that's warranted. So any questions about the 2022 work plan?
Jim, Dale here. Who are the members of the compliance committee?
The compliance committee includes the CEO, the COO, the CNO, the CFO, the chief of human resources, the executive director of physician services, legal counsel, the legal assistant, risk manager is also the privacy officer, and the HIM manager. I don't think I left anyone out.
Pretty well. There's it all.
Yeah, who's left?
Yeah, well, it's a broad committee, and everybody is very attentive during the meetings.
I didn't hear CIO.
Uh-oh.
I knew I was going to leave somebody there. Sorry, Jake.
That was the position I played in baseball, left out.
Left out.
Left out, yeah.
Are there any questions for Jim regarding his work plan for, or the work plan for corporate compliance for this year? Again, I think it's really important that the board knows what the plan is, and that Jim will be giving us I think, quarterly reports on findings that he has.
That's correct.
Is there any question from our audience regarding our corporate compliance work plan? Then can I have a motion to accept the plan as presented?
I move to accept the plan as presented by Jim Hook on compliance.
A second, please.
I'll second, Dale.
Okay, so it's been moved by Director Barnett and second by Director Shamlin to accept the corporate compliance work plan for 2022. Can I have a roll call vote?
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGeary,
Yes,
Director Brown,
Yes,
and Director Wong.
Yes. So again, Jim, your work plan for 2022 has been accepted, and we'll be looking forward to hearing reports on how that plan is coming along. So thank you again.
Okay, and thank you, Chair Wong, and if I may, next month, the Fox Group will be starting on its 7th year of affiliation with Tahoe Forest Hospital in this role as compliance officer for the district. So we want to thank the board and the administration for their support for all these years and look forward to several more.
Thank you.
thanks, Jim.
So, item 14.2 is a resolution from the board, and it's written in honor and recognition of our employees. And I'd like to go ahead and read resolution 2022-02. Is that right, Martina? Is it 02?
I believe that's 03.
No, 03, I'm sorry. So this is resolution 2022-03. Whereas Tahoe Forest Hospital District is a hospital district duly organized and existing under the local healthcare district law of the state of California. And whereas the Tahoe Forest Hospital District mission is to make a difference in the health of our communities through excellence and compassion in all we do. And whereas the ongoing pandemic caused by the spread of the novel coronavirus 2019 and the disease caused thereafter has created serious disruption throughout the region and within our health system. And whereas the winter of 2021 brought additional challenges for the healthcare system with unprecedented snowfall, road closures, power outages, and a surge of the COVID variant Omicron. And whereas the members of the healthcare team, physicians, it's on a light sensor. Whereas the members of the healthcare team, physicians, nurses, support staff, environmental services, and all employees at both Tahoe Forest Hospital and Incline Village Community Hospital work together to maintain safe and excellent care. And whereas throughout the especially difficult time, staff also took care of each other to cover additional staffing needs, carpooling to work, and helping one another to remove snow on and around cars buried under many feet of snow. And whereas each individual member of our district team together have been our first and best defense, overcoming challenges 24 hours a day, 7 days a week. And whereas the board of directors acknowledges and honors our entire staff on behalf of the community we serve, and to express our gratitude for their hard work, sacrifice, and tireless efforts to serve and protect our community during this historical holiday season. Therefore, be it resolved, the Board of Directors of the Tahoe Forest Hospital District do hereby proclaim its sincere appreciation, heartfelt gratitude to our healthcare workers for their selfless effort and sacrifice to make a difference in the health of our community through excellence and compassion in all they did during this unprecedented and challenging times. So we want to recognize the hard work that has gone on now and in the past and forever, and especially during the holidays when we know that the Omicron was just rampant. We were gathering hopefully to celebrate, only to find out we were spreading it. And yet there were people who sacrificed day in and day out to make sure that our patients had the care and attention that was needed. So are there any comments about the resolution?
On behalf of our team, we thank the board for your thoughtful resolution.
Very well stated.
Any comments from our audience? Then can I have a motion to approve and adopt this resolution?
Move approval. Yep, good.
Who seconded it?
I'll second, Michael.
Okay, so it was moved by Director Brown and seconded by Director McGarry to adopt the resolution 2022-03, recognize and honoring the efforts of the valued employees and healthcare professionals at Tahoe Forest Hospital District. Can I have a roll call vote?
Director Barnett,
Yes.
Director Shamblin,
Yes.
Director McGeary,
Yes.
Director Brown,
Yes.
and Director Wong.
Absolutely.
Alice, how will the honorees be advised of this?
Thank you for asking that. It's a segue into what I was just going to say. Is that I've been talking to Harry and Ted about what we can do in terms of having it printed, having it emailed, having something in the hospital so that all employees and visitors know how much we appreciate what sacrifices our staff has done. So with that, we'll continue to work on it, but it looks like it'll go into print and then it'll be distributed to our employees.
Okay.
Okay.
Can we send it to the newspaper?
Let me talk to the powers to be about what goes into the newspaper.
Yeah.
Okay,
Fair enough.
If you, Alice,
yes.
if you pay for it, anything will.
That's right, yeah.
Seriously, if you want to take out an ad and print the resolution, you can run it as it is.
I said, we'll be talking to the powers to be about that.
We hear you.
Yeah,
We'll take that into consideration.
thank you, Harry.
Director Wong?
Yes,
Sorry I didn't comment earlier. That was beautifully written. Thank you to the board, and I know the physicians and the hospital staff will really appreciate it.
we appreciate everything that they've done and how hard they've worked and the stress they've been under. So we want them to know that we see that and we honor them for it. So item 15, these are items that are just for board discussion. And our first one is the trauma program update. And we have Katie Clifford and Dr. Ellen Cooper. So you have the speaker.
Hi, good evening, everyone. I think I've met most of you previously. My name is Katie Clifford, and I am the trauma program manager. I've been holding that position for about 2 years now. I'm also currently the EMS coordinator for our hospital, and wearing the hat right now as the interim ED manager. I'm joined today by Dr. Cooper, our trauma medical director. She's on the line as well, and we have some updates for you all with the trauma program. Let me get my presentation going here. Sorry, Dr. Cooper, I didn't put your name on the front of it. That was my oversight. So as I'm sure most of you know, we had a visit from the American College of Surgeons this September. It was a very positive survey. They came out they came virtually to us over the course of 2 days. We got their report back last month, and that report has been sent to SSV. SSV is our Emergency Medical System Agency, so they oversee our region for emergency medical care. They're reviewing the report from the American College of Surgeons, and we anticipate that they will agree with the findings of the ACS, and they will be designating us as a level 3 trauma center this month. That designation will hold us until we can be verified by the American College of Surgeons. We actually need to have a second visit for them to do our official verification. We're working on scheduling that right now. The plan is likely for this fall. We're looking at September, October, November timeframe. So as soon as we get a confirmed date, we'll update everyone on that. So I wanted to take a second to just briefly overview the findings of the ACS. Overall, they were very complimentary of our program. These were the strengths that they identified. Some of the themes were just the strong relationships that we have developed in our program. Both between myself and Dr. Cooper, we work together very closely, very collaboratively on all of our initiatives for the trauma program. Also, our close relationship and support from hospital leadership. They have shown a strong commitment to the trauma program. Also, our close relationship with EMS. So we work very closely with CareFly, all of our fire. We go out and do trainings for CHP and police. We even work with our ski patrols. And we've been very collaborative and been providing a lot of education. We also have very strong transfer agreements for hospitals, both to the east and west side. So when we have trauma patients that exceed the capabilities of our facility, we're able to really seamlessly and easily get them to a destination that's better for them. Another theme from the findings was our strong commitment to education. We have 100% of our ED nurses who are trauma nurse core curriculum educated right now and hold that certification. We also, through a grant, were able to provide trauma care after resuscitation to our inpatient nurses. And we have around a 50% participation rate in different departments in the hospital. We also have a trauma fellowship trained orthopedic surgeon, which is a huge strength for our program. And it's actually fairly unique in the system. So they were very, very complimentary of that. As far as deficiencies goes, most of the deficiencies that they outlined were administrative tasks, some attendance to meetings, some other issues with our registry for our national trauma database that we submit data to regularly. So this was very encouraging because there wasn't a lot of clinical pieces on this, which speaks to, I think, the high level of trauma care that we provide to our patients at Tahoe Forest. There was one, and this is going to be kind of the focus of the program for 2022, is more engagement in identifying prevention opportunities and strategies for our community. The American College of Surgeons really believes that it is a trauma center's job to provide community education and identify prevention strategies for the members of our community in order to reduce the amount of injuries that we have, because we know that that's the best way to keep our community healthy. So I kind of broke down what that looked like. The American College of Surgeons outlines kind of their strategy. So we collect a lot of data with the trauma program, and they would like us to use that data to identify our most common causes of injury in our community. From there, we take a look at these causes and we try to identify if there are any root causes that we could target as educational opportunities. One that we identified this summer was that we've had a rise in e-bikes in our community. And since we've been seeing more e-bikes, we're seeing patients on bicycles getting more significantly injured. And so they also suggest that you partner with other organizations, Truckee, police, fire, the town of Truckee. Make it really a collaborative message, because that's the best way to amplify the message to the community. And also embracing the media, the newspaper, social media, radio, those sort of things to get the message out to the community. And finally, we utilize data surveillance. So taking a look at the data after a year and seeing, are we seeing a reduction in these injury patterns? Do we think we're actually, the strategies we're employing are keeping our community safer? And if they are, great. If they aren't, what else do we need to do? So this is something that we'd really love to, you know, take our program to the next step in this year. Trauma is never complete without sharing just a little bit of data. So these are our trauma volumes for the 2020-2021 years. As you can see, so this blue line are our modified traumas. These are our less significantly injured patients. Our full traumas are patients that we have significant suspicion that they may have a very severe injury. We are definitely, most of our patients fall in the modified trauma criteria based on their mechanism of coming from a ski hill or falling off of an e-bike. And I love this chart because I really think it speaks to what Tahoe Forest does, which is seasonal recreational trauma. So you can see we have our peaks in the middle of summer and the middle of winter, and we have our valleys in the mud season. We all know that mud season is becoming shorter and shorter, but it definitely is still there for our trauma volumes. So our total patient volumes for 2020 were 782. For 2021 was 729. That comes out to around 63 traumas per month average. However, as you can see, you know, some months will have over 100 trauma patients and some will have less than 50, just depending on what season it is. We took over 450 patients to our secondary review level. That means that these cases are pulled and Dr. Cooper and myself both do a deep dive into them to see if there's opportunities for improvement. When we find them, we do targeted education with staff, both inpatient, ER, EMS, police, ski patrol, wherever it may be, to try to, you know, improve the overall system and the outcomes for our trauma patients. So where do our trauma patients go after they come into the ED? So we have about a 64% discharge rate. This is pretty consistent with what the American College of Surgeons sets as a benchmark. Their benchmark is more around 45 to 55%. Given the nature of our trauma, recreational trauma is very difficult to triage based on presentation. The American College of Surgeons felt that this was a very appropriate number for us. About 13% of our patients are transferred to other facilities based on exceeding the needs of our facility. 11% are admitted to med-surg. We have about a 4% ICU admit rate, 6% going to the OR, and then we can't count out our 2% of patients who are discharged to jail. These are usually our drunk driving accidents, that sort of thing. AMA, these are patients who are leaving against medical advice. We have a very low AMA rate. So we, as a requirement for our trauma center designation, we must participate in TQIP. That is the National Trauma Quality Improvement Program. And we submit their data, and then quarterly we get reports back on how we're doing. We're benchmarked against other level 3 trauma centers throughout the nation. We've actually been recognized in our region by SSV as having lightning fast time to transfer. That means that when we get a patient into the department, we get their workup done, and if they need to go to Renown or Sutter or UC Davis or wherever it may be, we're generally getting these patients out in well under 2 hours. They're usually around an hour and a half. The benchmark by the ACS is set at 4 hours. SSV has actually asked us to come and present what we're doing in our program to get these patients moving through the system so quickly. And again, that just speaks to the collaborative nature of our emergency department and, you know, how we're triaging these patients and getting them where they need to be really quickly, and the commitment that the staff has made down here for that. We're very, very proud. So PI projects we've been working on this year, we're always identifying ways that we can make the system better. That's what trauma does, continuously improve. Just wanted to share a couple of fun initiatives we've worked on this year. Inpatient rib fracture pathway, we identified that nursing staff was having some concerns with admitted patients and pain control, particularly with rib fracture patients. So we developed a pathway. It's a collaborative protocol for nurses, respiratory therapists, and admitting physicians to work together to objectively assess these patients, and if needed, escalate their pain control and get blocks or whatever they may need so that they rib fracture patients who have successful pain control really get better a whole lot quicker. So this has been good for getting patients on their way to getting discharged and getting home and getting healthy again. Brain injury guideline. This has been one we've been working on with Renown. They've kind of, in the last 10 years, I'd say, been working on revising the care for a patient who may have a brain bleed. Typically, all of these patients, as soon as we saw anything on CT, we just sent them down the hill. That's where they went. With the new research that's been being done with the big criteria, there's now a group of these patients with tiny brain bleeds that we're able to keep here in the emergency department, observe for 6 hours, and then discharge home. This is a huge improvement for patient care. Not only does it alleviate a costly transfer for a patient to another facility, as well as another ED charge, but they're also not removed from our community. We know that patients who get transferred to Reno and discharged from the ED have a huge inconvenience of trying to get back. So we've been really proud of the work we've been able to do with the big guidelines. And we have had, so far this year, we've had 2 patients who are able to be discharged from our facility with brain bleeds. So it's happening. Finally, we have our substance use navigator. I think this slide, I'm so sorry. This is 2 of them put together, but our substance use navigator is doing audits on 100% of our trauma admits. We know that trauma and substance use go very, very closely together. For some reason, people like to get drunk and do silly things and then hurt themselves. So our substance use navigator, who works down here in the emergency department, will do an alcohol screening on 100% of our admits. And if she identifies opportunities, she will provide them with resources to get the help that they need. So far, since Claire has started working, we have had, I think, at least 3 patients that she screened that were actually looking for resources, but didn't know resources existed in our community. So she was able to hook them up with the appropriate resources so that they could get that help, and likely, got them on the road so that maybe we won't see them down here in the ER again. So we love the work she's doing. And that is all I have, but happy to answer questions, or Dr. Cooper, if you have more to add.
I don't have more to add. I think you did a great job of giving a good overview of how much progress we've made and all the exciting things that we are in progress with right now.
Have any questions for Katie
Yes,
or
Alice?
Dr. Cooper?
Alice Dale here.
Yeah.
If I may, Katie, I remember Ellen telling us several months ago when we first got our trauma designation that 27% of trauma victims who show up in our ER are bike enthusiasts, 20% are ski and snowboard. I've seen the efforts, particularly at Squaw Valley. In Alpine Meadows, I don't know, or excuse me, Palisades Tahoe and Alpine Meadows, to slowing people down in pinch points. I'm not sure if any of you are aware, but about 8 years ago, Ski Magazine wrote an article about the 10 most dangerous slopes in North America. They included incredible chutes in Jackson Hole, Corbett's Couillard, Spanky's Ladder at Whistler, so forth. But number 8 was the mountain run at Squaw Valley on a Saturday afternoon.
100%.
And as I'm fond of saying, it's a mixture of Ferraris and tricycles, and they don't blend well. As a ski instructor, we are directed not to bring anything less than an advanced class down the hill on the mountain run during those periods of times. So I can understand in the case of ski and snowboard how you could have programs to mitigate injuries. But bicyclists are kind of a different breed. They're out there on their own, doing their own thing. And I'm just wondering, what kind of efforts do you see the biking industry, which is the bulk of the trauma cases, other than putting training wheels on the bicycle, how would you attack that particular problem?
Do you want to take that, Ellen?
Well, I think there's a couple of ways we could approach that. One is that we see e-bikes as a particular niche of patients and trauma patients who we tend to see people who may not have the physical fitness or the familiarity with bicycling, renting e-bikes. And so the e-bike rental locations could be a targeted place where we can put additional material up. Social media could be a great opportunity. We all know that everybody follows CHP Truckee on a regular basis for their ski and road conditions. And so we could partner with them to help teach people about the risks of e-bikes. And then there are really popular trails that people come on that we could potentially use as inroads to educational points. Finally, I think that the North Star Downhill Park is also another area that we could work with to encourage people to make safe choices when they're learning a new skill like downhill mountain biking.
Could I add one more?
Yes.
I'm of TAMBA, the Tahoe Area Mountain Biking Association, and I've done trail building with them. Their trails are more slope trails rather than steep, rocky trails. And I would suspect that most of the injuries come from those steeper, rockier trails rather than the flow trails. And I'm just wondering, if you aren't aware of TAMBA, that you might partner with them too.
Oh, we would love to. I think that's a great idea. And I think the development of flow trails in the community is probably going to move the needle a little bit on safety. Though, I mean, we see some pretty significant injuries coming off the rim trail, and some of those, the flume trail, all of those can have pretty significant injuries, either with kind of lapse of attention in the even an experienced bicyclist, and then sort of unusual crashes. So there's injuries everywhere on the bike trails, but I think TAMBA is a great idea.
This is Bob. Dale, I want, since Dale and I ride these bikes together and they're out there, I don't know, 60, 70 days a summer, I would add that padding seems to make a difference. I mean, I just have to say, from my own personal experience, when I go to the bike park, I make sure I'm padded up from top to bottom. I mean, hip pads and knee pads, and I have shoulder pads to prevent the shoulder separations that are so common. Anyway, that's an area to look at. And then in addition to TAMBA, there's Truckee Trails they're doing quite a bit of building around Truckee, and they're a great organization. And then finally, there's the Land Trust that are doing a lot of building. So another great organization. So that's my comment.
Perfect.
Questions or comments for Dr. Cooper?
No, terrific presentation, and thank you very much.
Yeah, great.
I want to add just the one thing I think that Katie, that we don't reflect on enough is that, like, Tahoe Forest was able to do this essentially in the midst of the pandemic. And there was a lot of divided resources and a lot of energy going in a lot of different directions. And I just think it speaks to what Tahoe Forest does and who we are, that even when resources were thin, our ER docs, our ER nurses, our EMS agency, our surgeons, everybody was really engaged in this. And it could have been a time that things could have fallen apart. But it's been really, really gratifying to watch Tahoe Forest do this, even in circumstances that were challenging.
And Dr. Cooper, I want to say big kudos to you, because it was of your leadership that people wanted to follow and make this program successful. So big kudos to both you, Dr. Cooper, and Katie. Thank you so much.
Yeah, good work.
Absolutely.
Thank you again. Thank you for all the work you've done. And I know our community will be very pleased to know that we are a trauma center now, that we can provide some of those services so they don't have to leave the area. So
Yeah.
thank you again.
Our
for your
last
work.
minute plug is we want our sign. We need a sign that celebrates what we've done so that when people arrive at Tahoe Forest in their Ford F-150 with their mountain bike in the back, that they know they're coming into a trauma center.
Well noted, Dr. Cooper.
Thank you.
Thank you all for your time and for having us.
Thank you.
Uh,
Okay, so we'll move on to item 15.2, our wellness neighborhood update, and we have Maria Martin, who is going to do that presentation.
Hi, thank you very much for allowing me to present tonight. I'm Maria Martin, and I am, let's see what we got here. I am the Director of Wellness Neighborhood and Community Health, and Lizzie Hennessy is also going to be presenting with me tonight, and she is our Population Health Analyst. And I am going to try and share my screen. We'll see if this is working. Martina, I don't know if I shared it. It seems to be, I'm not seeming to be able to get to it.
I can share it for you.
Thanks, Martina.
Sure. Just a second.
Okay, actually that one is the annual report one. It was the PowerPoint one that we sent out. When I
think it's
had
right.
some,
Okay.
great. Okay, so actually, so what I wanted to do is I wanted to begin with a description of some common terms that are used when describing strategies to improve community health. A lot of times they're used, they reflect some different things, but a lot of times they're used interchangeably. So public health is often associated with government health approaches and focuses on looking at entire populations. Most likely that's more of a county or a state. Sometimes it's a neighborhood, but usually it's a larger population. Their approaches include like policy, formative research, and environmental approaches to improve health. When we talk about community health, we're looking more at a more local geography. So it could be a town, or it could be a service area. And it also uses strategies, more collaborative strategies, partnering with different organizations and specifically targeting the needs of that specific community. And then when we talk about population health, that's a term that tends to be more focused on health care specific interventions, clinical interventions that are focusing on the needs of patients with specific diagnoses. And no matter really what terminology we use or who spearheads the initiatives, the public health, community health, population health, they all take a long-term view of patient health and wellness, and really looking at strategies to keep people as healthy as possible for as long as possible. Next slide. So the other thing that's similar between all of these is that they all use data to identify patients that are at risk. They all benefit from looking and understanding and addressing social determinants of health. And they all are outcome driven to improve health. And so some examples of outcomes are like state policies to increase immunization rates would be an example of a public health outcome. Nutrition education to increase fruit and vegetable consumption could be an example of a community health outcome. And increasing depression screening and follow-up rates in primary care as an example of a population health outcome. So why is it important to address population and community health for health systems? Well, if we really want to improve the health of our population or people, we need to recognize that 80% of health is influenced by factors that are outside of healthcare access and the quality of care that patients receive. And these other factors include health behaviors by the individual, the impact of the physical environment, or socioeconomic factors. We also know that by doing screening and early identification and health education, we can improve patient outcomes. We know that by engaging our community, it increases trust and awareness, and it brings people to the health system to link with primary care. Community collaborations allow us to leverage limited resources that the health system may have, so it lets us do more with less. And by addressing our community health needs, we demonstrate our accountability to our community members. So what the Wellness Neighborhood does is that we help to address the needs that are identified in the Community Health Needs Assessment. The Wellness Neighborhood in its current form was kind of initiated back in 2012, and that was following the first needs assessment that we conducted. The health system brought together providers and community partners to work together to develop strategies to address these 4 key focus areas, which were identified in that needs assessment and really have essentially stayed the same in the 2 subsequent needs assessments. And in wellness, we kind of work on 3 different levels. We work to support the health system by seeking and managing grant funds to implement projects and establishing and maintaining our community collaborations. And we support our providers at all levels by providing a referral resource for their patients to help their patients better manage their conditions. And we also promote meaningful change by helping to identify patients at risk. And we support our community members by the actual education that we offer to help individuals optimize their health and well-being. So how do we do this? Well, we use quite a variety of strategies to improve community health. A lot of times when people are thinking about community health, they really focus on classes and one-on-one education, which is something that we offer, but it's only kind of a piece of what we do. We also implement broader community interventions like school-based interventions, prevention activities. We support affordable labs for community members who may not have insurance coverage. We do health challenges. We do health screening events at community events, although those have been kind of minimal the past couple of years. And we also have staff that really provide support for our high-risk patients, more targeted education and support. And then finally, we lead or we participate in a variety of different collaborations. Some of the collaborations are internal to the health system and where we focus on identifying ways to improve identifying patients at risk through policies or workflows or efficiencies in the electronic medical record. Our collaborations with our community partners, such as the ACEs Trauma-Informed Care Coalition, or the Immunization or Dental Coalition, allows us to expand our reach and leverage each other's expertise. And so our large successes are really a result of these working together, these working collaborations, both internal to the health system and in the community. Okay, next slide. So what I want to go over next is I'm just going to highlight some specific projects that demonstrate successes in our 4 focus areas. And it's not a complete listing of all of the programming that we have. And since I'm kind of talking about all different areas, if you have questions on a specific area, I'm fine if you want to ask them as we're going along, whatever works best for you. Okay, so the next slide we can go to, I'm going to talk a little bit about one of our behavioral health goals. So one of our behavioral health goals was to increase access to mental and behavioral health services through universal depression screening. And fiscal year 21, we continued in the second year of our HRSA grant, and it is our work to identify patients at risk for mental and behavioral health services. We were awarded a 3-year HRSA grant, which brings in about $200,000 a year. All of those funds went to support behavioral health staff. And in this year, what we were doing is we worked really closely with multidisciplinary teams in both adult and adolescent primary care. And our goal was to implement depression screening workflows and develop plans to refer patients that are at risk and follow up and rescreen those patients with elevated scores. So we started a pilot with adult primary care where we looked at the impact of screening every patient at every primary care visit. And following our pilot, the primary care committee chose to adopt that practice and continue it forward. And Lizzie's going to talk a little bit about the results that we saw from that pilot and where we are today with that.
Go ahead, Maria. So
You wanna
this
go ahead?
graph, yeah, we track a bunch of different metrics, but we wanted to give an overview of the impact that this pilot and this collaboration has had on our patient care. And you can see that our baseline was before we really had a universal screening process. There were depression screenings happening, but mostly for the Medi-Cal population under the PRIME program, if that's familiar. And you can see our rates have increased remarkably, and not only has our percentage or proportion of patients who are screened increased, but if you look at the table labeled population, the number of people has increased 600% of patients, of adult patients have been screened. That's a huge increase. And for our adults 18 and up, our adolescents 12 to 17, you can see that increase from 229 patients to 688, it's around a 200% increase. But really, we're on that graph where you see it start. You can see the increase right there is the impact of switching to a every visit screening, and why they choose to do that. The screening tool itself only asks about a 2-week window. So if a patient's only coming in once a year, you're likely to miss that 2-week window where they may have some additional needs. Behavioral health, the whole department advocated for a more frequent screening process. And then through the pilot and through providing education and talking about the burden that it would put on the front office to try to identify those who are actually due for annual screening, it made sense to shift to this model. So we have other data as well, obviously on those who are scoring high. And we actually disaggregate the data to look at subpopulations who are at higher risk of depression. And unfortunately, our youth, the elevated scores are increasing this entire time we've been tracking it through this whole pandemic, whereas the adult rates are actually decreasing. So as we stand looking at the last 12 months of data for unique patients who are screened, around 18% of our youth are scoring that they need some additional mental health follow-up care.
Thanks, Lizzie.
Yep.
Okay, we can go on to the next slide. So
Before we do
another
that,
goal.
I do have a question. Can we go back? One of the items that you presented was the ACE factors, the adverse childhood experience factors. And on your slide that I read with the packet material, it showed that if you have 4+ factors, that there's a high correlation between depression, alcohol, and interestingly enough, cancer. And so I know from other presentations that our level of depression and alcohol seems to be high as a community need. And I just wonder if those ACE factors are a contributing element to the depression and alcohol issues.
Very interesting question, and something that we can talk a little bit more as we get into the later slides where we're going to talk quite a bit about ACEs. But yes, that is a possibility. We are at the beginning stages of screening our local patient population for ACEs. So we don't really have an answer for our population specifically, but we can say that, what you saw was that those people that have higher ACE scores tend to have these other risk factors.
Okay, thank you. I just wondered about that correlation.
Yeah, and we'll talk a little bit more of that as we get to towards the end of the presentation.
Okay.
Okay. Any other questions about the depression screening? Okay, so another behavioral health goal was to expand our suicide prevention activities through safer suicide care. And so in fiscal year 21, we continued to move forward with the Zero Suicide Initiative. And this is it's actually an international evidence-based approach for suicide prevention for health systems. So this year, we finalized a system-wide policy to manage patients at risk for depression, self-harm, and suicide. And what we found is that we had a lot of little bits of, in many different policies, there were areas that referred to suicide care and screening. And so what we did is we consolidated all these policies. We included practice guidelines for the different departments, and we really clarified the roles of the employees that are doing the screening and follow-up of suicide risk.
Another element that we worked on based on a survey that we had completed in 2019 to identify our staff needs was building the Talk Saves Lives for the Workplace into HealthStream. And this is an online module that employees can take at a time that's convenient for them. And we've had great feedback and that it's paced really well. It's around 45 minutes. So it's not a huge investment in time, but enough of an investment that people walk away understanding the signs of suicide, understanding how to respond and the next steps. So we found that we've really gotten wonderful feedback from it. And we got support from Tahoe Forest Health System leadership to require that for all Tahoe Forest Health System staff and team members. So it was a great success for the fiscal year. We wanted to ease into the training and let people know that we have been impacted by this personally as a health system, as a community member. And so we chose to create a customized introductory video with our staff. We asked for volunteers, kind of picked some people and said, would you be comfortable being part of this introductory video? So we had some people from various departments in different languages do the ease in because we didn't want to trigger anybody with the heavy topic. And we wanted them to feel comfortable in knowing what to do next if they were ever in that situation where they felt a friend or a loved one was experiencing suicidal thoughts.
And we also did a lot of awareness activities for our staff before we launched this. And one of the key things that we put into place was an intranet page for the Zero Suicide Initiative, where people can go to get information about zero suicide and find resources on that page. Specifically, you can find resources in the community if you need it now. You can find targeted resources that we have for our own employees that may be feeling at risk or are concerned about a coworker. And then there's also a place on there for community trainings for people that really want to learn more and kind of enhance their skills around suicide prevention. On our intranet page, we promote the Know the Signs California campaign. And interestingly, right now, as we're doing this meeting, simultaneously, the Suicide Prevention Coalition is offering a virtual Know the Signs training. And this was at the request of the Nevada County Supervisor, Hardy Bullock, and in partnership with Nevada County Public Health and our own health promotoras, they're providing the simultaneous Spanish translation for tonight too. So our next steps with the Zero Suicide Initiative is that we're going to be focusing more on evaluation. We're going to be looking at the areas for refinement, or how we're going to fine tune workflows, or if there's any areas where we need additional training. Okay, so in substance misuse, our work here is really focusing on more upstream approaches through community education and partner collaboration. So these are a list of some of the prevention activities that we did in fiscal year 2021. So we offered a community talk called The Basics of Youth Substance Use with our own psychiatric nurse practitioner and the the pediatric care coordinator. We had about 68 people attended that. It was really appreciated. The Wellness Neighborhood supports the Alcohol EDU program, which is a curriculum in our Tahoe Truckee Unified High Schools. And about 319 students participated in that this year. And we continue to collaborate with Tahoe Forward, which is the Tahoe Truckee Future Without Drug Dependency, to help them support their drug takebacks events. So for fiscal year 21, they collected 218 pounds of prescription drugs that were able to be destroyed, so that they're not in the home and being misused by someone else. We also offer nicotine cessation coaching. We completed 87 sessions this year, and really good news for this current fiscal year is that we're going to be offering that in Spanish as well as English. And then we promote Alcohol Awareness Month, which is in April, and encourage people to take an alcohol-free weekend as just a general community outreach event.
So in addition to the upstream approaches, we support our clinics and our behavioral health department in overseeing the funding that supports our clinical psychologists in supporting patients who are part of the MAT program. So medication assisted treatment are those who are on some sort of medication for opioid use dependence. And as a piece of that, they're, I don't know if required is the right word, strongly encouraged to see the clinical psychologist. And what the clinical psychologist found is most of the time there is an underlying trauma, and helping that individual address the trauma can help them move beyond the opioid use dependence and become a contributing member of society. So we can see in the graph that's showing that in our baseline fiscal year 19, we were able to support at that point 32% of our patients who had co-occurring diagnoses of depression and opioid use dependence. And now we are up to 61% of our patients who have those two diagnoses are participating in our MAP program.
Okay, so one strategy for supporting patients with chronic disease is the targeted support from a health promotora. And not only do they help patients manage their chronic disease, but they also address the impact of disparities that this population often experiences, such as language barriers or literacy barriers, cultural barriers, or financial hardships. So a promotora is looking, I mean, one of their main things that we're having our promotoras work on is improving access to care and addressing barriers to care. Our promotoras are from the community. They are trusted community members who are also part of our Tahoe Forest care team. They are all bilingual and bicultural, and they receive a lot of additional training to really expand their skills and the services they can provide. They are qualified medical interpreters. They lead our self-management program. They are the program, you know, we train them all as leaders. They have skills in health coaching and motivational interviewing, and some as peer supporters. And we are working to get all of our promotoras certified as community health workers. And this will give us the opportunity in the future to actually get some reimbursement through Medi-Cal for the work that they're doing. We can go on to the next one. So how they help our patients. So they do a variety of things. They provide a lot of community outreach. They are out in the community and providing education. Our promotoras this year actually helped Nevada County Public Health with the COVID contact tracing in the Hispanic community, and helped with vaccine education as well, COVID vaccine education. They lead support groups, they lead workshops. They do a lot with helping our patients get the medical, social, and financial resources they need, whether that is a lot of times just, you know, applying for things that they're eligible, educating on what types of resources are available. I think really the most, where we really see the benefit in the health system is that they act like the bridge between the patient and the providers so that both of them can be successful. They make sure that the patient is really understanding the care plan that their provider has for them. We found that a lot of barriers in people following their care plan is they don't really understand what they need to do, whether it's because their language skills aren't well, or we find a lot of patients, it's just their literacy level. So the Promotoras help to put the information in a way that the patient can understand it so that they can be successful with their care. And patients get to a Promotora by a referral from their health provider. So the patients that they're working with are those with complex medical conditions, patients with disability, mental health needs, any of the barriers that we address below. For those patients that just need translation service, using the language line is the appropriate translation resource. Okay, and the next one, so the other strategy for preventing and managing chronic disease is the role of nutrition. We offer a variety of resources to help people reduce their risk of developing chronic disease, our prevention activities. One of our key ones is the Diabetes Prevention Program. This is a program where we had to obtain recognition from the CDC to be able to offer it. It's a year-long lifestyle change program at risk for people at risk of developing diabetes. They cannot have diabetes already and be in this program. So we're really trying to identify those people ahead of time. It's pretty intensive because the program goes for a year. In fiscal year 21, we completed 3 cohorts. So we kind of overlap them. We've completed 3 and we started an additional 2. And we offer this program in English and Spanish. Cooking Club is a health supportive cooking demonstrations that's really gaining in popularity. It's really hands-on and practical and different topics each month that we offer with our dietitian. And then we've offered a variety of targeted nutrition education on various different topics, from pregnancy nutrition to infant and toddler nutrition, cancer prevention, nutrition for cancer prevention, how to eat local in the Tahoe Truckee area, and a popular one was nutrition for your immune system as we're going through the pandemic. And then finally, the other prevention activity that is in the schools, which is a school-based nutrition activity and wellness program. This program, we're at a little bit lower outreaches than we were before COVID, but right now we're still reaching 74 classes and over 1,400 students a month for each of those programs for BFIT and Harvest of the Month. And then for those who have chronic disease, we have strategies to help people manage their conditions more appropriately. So we offer nutrition consultations. This is medical nutrition therapy in an outpatient basis. It helps patients create personalized plans so that they can address their health conditions. And we did over 760 consultations this past fiscal year. We run self-management programming. This was originally through Stanford School of Medicine. It's a 6-week program, self-management program, where nutrition plays a key role among other things. And we reached 7 different cohorts in the self-management program this past fiscal year. And one of the specific ones that's not so much, it's for the caregivers of someone with a chronic condition. The Building Better Caregivers class is something that we learned that we're really in need for. We have a lot of caregivers in our community who are taking care of a family member, and they need support and resources as well. And that class has been very popular. Okay, and then our last focus area has to do with prevention and wellness. And one of our goals under prevention and wellness is to increase preventative screenings. And so the one we targeted this year was screening for ACEs. So I'm going to give a little bit of background on ACEs because a lot of people are just starting to learn more about ACEs and may not be really familiar with the term. So ACEs stands for Adverse Childhood Experiences, and it refers to traumatic events that occur in childhood and fall within the categories of abuse, neglect, and household challenges that are outlined in that image. So when someone's exposed to these types of events, they can contribute to a prolonged activation of the stress response. And this prolonged activation is called toxic stress. And there is a dose response relationship between the number of ACEs a person has and common health conditions. And so when we look at ACEs, we find that they're relatively common. So in California, 62% of Californians have experienced at least one ACE, and 16% of Californians have experienced 4 or more ACEs, which put them at pretty high risk. We can go on to the next slide.
So this gets to what the director was referring to earlier. There is a direct correlation between ACEs and your risk level for multiple chronic diseases, as well as substance use issues. And we broke these down. There are many you can choose from. They are research. There's different papers pretty much on each one of these. So we wanted to choose one from each of our 4 focus areas. So you can see in pediatrics, under chronic disease, you have asthma, obese, and overweight. There's a greater risk. This is looking at those who have 4 ACEs and the odds ratio, so increased risk. For mental health, there's nearly 4 times the risk of depression. Learning behavioral problems, you can see, is really huge. And then first use of alcohol younger than 14. Adults, you can see the same thing. Chronic disease, you have cancer, cardiovascular disease. You can really choose almost any health topic and look at the impact that ACEs has had on it. And I find it challenging to really explain why, but I think the easiest way for me to understand it is when you experience all these ACEs and this stress level daily, your body starts to just live in this constant state of reaction. And basically, how I can interpret it, it's increasing the inflammation in your body. So over time, it has these significant negative health outcomes. But the good news is that just because you have ACEs does not mean that you're going to develop these health symptoms. One of the key pieces of this is having a supportive adult in your life. It doesn't have to be a parent. It could be a teacher. It could be a coach. It can be anybody. But the impact of that supportive relationship is huge. So the Stress Busters wheel on the right is emphasizing more of these buffering factors. So it's all basic stuff that we're doing. It's having supportive relationships. It's getting enough sleep. It's eating well. It's exercising, mindfulness practices, getting outside in nature, and having access to mental health care. So all of these really help buffer that toxic stress in your body that can help prevent any of these negative health outcomes. And there are hundreds and hundreds of pages of research that I can share with you if you're interested. But it's pretty fascinating. And these, we were lucky to get a grant this year. Maria, did you talk much about the grant?
No, that'll be the next one.
Okay, go ahead.
Yeah. But one other thing to say about that is that what Lizzie was saying is that just because you have ACEs, it doesn't have to define you. And when you talk to people about when you screen for ACEs and you talk about these buffering resources, it really gives people a lot of power to realize that they have control over how they can react to the situations from their past, which they had no control over. So the reason we had this kind of big buildup is that we were a recipient of the ACEs Aware Trauma Informed Network of Care Planning Grant. And I know that title is a mouthful, but that's actually what it was called. We received about $300,000 in February of 2020, and the grant went until September 2021. It was a very rapid turnaround grant. The objectives of the grant were to identify and implement strategies to increase ACEs screening and to create and sustain a network of care to support those at risk of toxic stress. And so what we did in the grant is we implemented 2 simultaneous work groups. We had a pediatric clinical work group, multidisciplinary team representing all levels of staff in the pediatrics department. And then we convened a community network of care leadership work group, which had representatives from all of our community partners that are listed at the bottom of this slide. Some of the things that we accomplished is that we had 21 of our medical providers completed the ACEs Aware provider training that provided training on ACEs and toxic stress and the kind of the medical protocols around it. And that also allows them to bill for ACEs if they do an ACEs screening. We developed an ACEs screening and follow-up workflows for pediatrics department. so that we could implement a pilot. And this process also included integrating the ACEs screening into Epic along with the billing codes. And we identified patient education materials, and we had it translated, and we put everything in place for a pilot in pediatrics. And then we created this network of care with our community partners. This first part on here about this bi-directional platform, this was actually part of the grant deliverables, but they really wanted all the teams to explore ways to communicate and refer to each other. And this, what we looked at was options for a bi-directional platform that would kind of eliminate the silos between the agencies that can provide some of these buffering resources, improve efficiencies in trying to access care, and really act as a way to help us gather more data in both the health system and the community to demonstrate community need. The other thing that's really interesting about our work on this ACEs Aware grant is that the Surgeon General, the US Surgeon General, recently just put out a report called Protecting Youth Mental Health. And in that report, he highlighted the California ACEs Aware Initiative. And what was specifically appropriate for us is that he looked at, you know, what counties can do, what individuals can do, but under the area of what healthcare organizations can do to support youth mental. It includes screening cases, implementing trauma-informed care principles, and identifying those at risk and linking them to resources. And so we really feel like we are kind of on the cutting edge of this next step, and we are set ourselves up for success in moving forward with this ACEs screening. So for our next steps with this is we right now are in the process of our pilot project in the pediatrics department. And we hope to use the lessons learned from this pilot to allow us to expand our ACEs screening. And we are also continuing to meet with our network of care partners. We want to further the process of implementing trauma-informed care in all of our organizations. And we are working on strategies for community education around ACEs and toxic stress. Okay, so that completes kind of our overview of our successes from fiscal year 21. Wondering if anyone has any questions for us.
You answered my questions, and I have to say, I think you're really headed in the right direction. And I think that it's really heartwarming to see that we're reaching our healthcare out into this community of people and really identifying their needs and being able to give them not only hope, but resources. So I am very impressed with what you're doing. Thank you for that.
Maria, Dale here. Would you review with us what the budget of your department is and what, if anything, the individuals who use these services pay for those services? Are they provided at no charge?
Yeah, the vast majority of our services are provided at no charge. If some things might have a small fee, but we will cover the cost for anyone who is referred by someone or is not able to afford it. The budget for the Wellness Neighborhood Department, I don't have the exact number, it's about $800,000. And we are supported through a portion of the property tax revenue. So we're giving back to the community.
Are we unique or do other hospital districts have similar programs?
I think, well, a lot of other hospital districts do have places or other nonprofit hospitals where they give back to the community. I think what's unique about our program is that we've really developed strong partnerships with our community, and we are kind of embedded and doing the work, a lot of the work ourselves. We do give some support to community organizations out of that same pot of money, but we don't use the funds just to give grants.
Okay, thank you. Mary, you're muted.
I have a dog that barks, so I always put it on mute and I forget. But but thank you for this, both of you. I mean, I'm always heartened at this time of year when we get this presentation, because to me, it's so much of what we're about and what we're, you know, what we're obligated to be doing. It's what we're supposed to be doing. And I just wish that there were some way that could be devised that we could really measure impact and quantify the impact that we've been able to make on the community as a result of your good work. Is there anything
Yeah.
that
Well, we are in the process of analyzing the most recent community health needs assessment. It's a challenging year to do a needs assessment, and actually I'll be coming back next month to share those results with you. But we did have a couple of big successes that we'll be able to share. We also had a lot of setbacks with COVID and people not seeking care. One thing that I'm working towards for the future, and hopefully we'll get this in place sometime this fiscal year, is we're looking for how do we quantify what we do in terms of addressing the social determinants of health. And so I've been looking at different strategies of how we could do that, because we hear anecdotally, you know, how much we can help people and how we've moved people from, you know, one place to another and improve their health, but also improve their living conditions. And I'm looking for a way to be able to quantify that. So I think that would get to your question.
That would be wonderful. Thank you.
Any other comments or questions for either Lizzie or Maria?
I was going to share one behavioral health stat that really is directly related to the grants supporting behavioral health. Of those patients that score high, if they are linked with behavioral health services, they could be outside of our health system or within, and they're re-screened within 4 to 8 months, which is a HEDIS measure. We are seeing 50% reduce their PHQ scores. That's a screening tool we use. So as Maria just went over, 40 of the programs we see, you can break down the data in so many different ways, but at least that's one look into the impact it has of organizing and coming up with a uniform approach and educating our health system on what the follow-up is, encouraging them to rescreen patients. So I think that's wonderful. 50% of our patients scoring high is reduced.
That's great.
Thank you for that, Lizzie. I think when we talk about quantifying, those are the kind of, that's the kind of information the board is looking for, because certainly we know that you are putting out your best work in helping our community, but how much is that work affecting the community's health? And I think, data like you're showing us with behavioral health really is what we're looking at. So thank you again for that. Maria, we always appreciate all the work that the Wellness Neighborhood does for our community.
And we'll look forward to the community needs assessment.
We have been looking forward to it.
Yes, it's been taking quite a while. We were on the phone with our consultant today. So
well, thank you again. Okay.
Thank you very much.
Okay, then we'll move on to 15.3, and that's our medical staff press Gainey engagement survey. And is Alex going to do that?
Yes, hello.
Okay.
It's going to be me. Yes, thank you. So I'm going to keep this fairly brief. I know you all have seen the results. A couple of things I want to point out is that this was the medical staff engagement. This year we did include our advanced practice providers. So I'm going to jump right into the results. Now, engagement is one of the overall scores we look at. Engagement's a composite metric of 6 items that measure degree of pride in the organization, intent to stay with the organization, willingness to recommend, and overall satisfaction. It's really the primary metric we look at. Now, I want to give kudos to Dr. Cole because she did do something a little bit more unique this after we received the results, because she wanted a better understanding of what organizations were doing since 2019. Oftentimes, since you've seen me present different presentations like this, we compare ourselves to just the last time look at the survey. And in our case, for the medical staff, was 2019. And so I just got a notice that my internet is unstable. So I apologize. Can you all hear me?
Yeah.
Okay.
Yeah.
So what Dr. Cole did was she reached back out to Prescati and said, you know, we really want to understand where we would have been in 2021 and where we would have been in 2022. And this gives us a good picture that you can see since 2019, we were 0.03 below the national average. If we were to compare that to 2021, it's 0.06 above the national average. In 2022, it'd be 0.14 above the national average. So it really gave us a better understanding of where we were falling from 2019 and giving the future years as well, 2021 and 2022. Now, this still paints a picture that we've got some work to do, right? And so I'm going to go over a couple other things here with you. When we look down here at the organizational domain, it's really the degree of which medical staff feel connected with the overall organization. And the staff domain is the relationship with hospital staff, nurses, and hospitalists. The leadership domain is the perceptions of organizational leadership, departmental and senior leadership. And the department domain is really assesses the performance of key service providers, OR, lab, ER services, and those types of things. I'm going to go right on here. And, you know, one more thing on here, you know, just to go back to giving kudos to Shawnee, looking at this, I think you'd all agree that many, many things have changed in healthcare since 2019. And it's been remarkable to see that, you know, even though we've got a lot of work to do, organizations, even great organizations, great culture like ours, we still have work to do. So I'm going to jump right into the strengths. I'm just going to read a few of these. I know that you have had a chance to review, but maybe the top 4. Overall, I'm satisfied with the performance of the emergency department. And by the way, I should point out that the strengths are identified through the application of an algorithm that considers performance score, percentage, favorable, and a positive difference in the from the designated national benchmark, excuse me. Number 2, there's an effective teamwork between physicians and nurses. 3, there's effective communication between nursing staff and physicians regarding patient care. And number 4, patient care between shifts is effective at the hospital. All really, really positive stuff. I want to focus a little bit more on the concerns. So the concerns are identified through application of an algorithm that considers performance, same type of thing, but you know, the opposite of strengths. And so if we go through these, you can see we've got number 1 is I'm satisfied with the ease of scheduling process for my patients. So obviously this is an area that we need to focus on. I rarely lose sleep over work issues. I'm able to disconnect from work communications during my free time. I'm satisfied with the recognition I receive. I'm satisfied with the availability of beds at the hospital. I'm able to free my mind from work when I'm away from it. The organization provided training on best practices for virtual visits. Organization demonstrates a commitment to workforce diversity. The organization values physicians from different backgrounds, and all physicians have an equal opportunity for career advancement regardless of their background. So let me go through a couple of these real quick. So we've talked about the engagement indicator. The alignment indicator is the level at which medical staff feel a strong partnership and connection with leadership and have a shared vision of how to execute the mission. And that their input is valued and they have impact on the goal setting and direction. The resilience indicator is the ability to recover and remain engaged even in challenging work circumstances. And that's broken into 2 different things. Activation, focus on finding meaning in the work they do. And decompression is focusing on the ability to disconnect from work when not there. These are really important to us. We're going to talk a little bit about that after. And then of course, the diversity. And diversity is the overall assessment of diversity-based issues of importance. So some of the comments that medical staff providers had in the survey was working for Tile Force is my dream job. I love that. They have more medical providers and leadership positions, or excuse me, have more providers and leadership positions. The right slide here. They have worked in medicine and understand medical staff needs and the workflows better than non-providers. Regarding behavioral health, transitioning to full-time into the MSc at IMCARD has improved collaboration. Hospital is doing a lot of things well. The biggest challenge is manpower and space. Keep working on this. Leadership from medical provider was wonderful, and everyone that worked in the RIC helped each other every day. I look forward to going to work every day. And last comment, that we've put up here is the way the health system managed COVID was exemplary. It took a huge burden off of not having to worry about workplace safety in the midst of the pandemic. So what are we going to do with all this? Well, the first thing we have to do is understand the data in more detail. That's really important. So we're going to be holding focus groups. We're going to identify opportunities for enhancement, engagement, alignment, and resilience. Identify opportunities to improve practice environment and work to eliminate identified operational hassle factors. Discuss, of course, with MEC in detail and achieve consensus on all areas of focus. We need to identify physician and advanced practice provider champions to assist with action plans based on the feedback. They're going to help us execute a lot of these things. Of course, communication is key. We're going to communicate strategies and tactics that have been developed and report our progress. And then another thing, which I talked about on the resilience piece, was we have to identify and implement evidence-based tools to prevent burnout and enhance resilience. That's really a huge piece of this. You all have heard of the 3 Good Things app, where you basically, every day you take time to write down 3 good things, and it really improves in areas of depression and just overall burnout. Now, in closing, I'll just repeat, our score was 4.17, which is 0.06 above the national average. We had a 78% response rate. This is really giving kudos to Sean Cole. She was texting people, she was calling them, telling them to fill out the survey, and that's actually remarkable. People don't usually see a 78% response rate. It's important to know that we value the feedback and are working to understand the data in more detail so we can thoughtfully put actions in place for improvement. And we're going to continue to focus on the resilience index, which measures the early signs of burnout. It's important to us that all of our employees, including medical staff, find joy in their work. With that, I'm happy to take questions. And I think Shawnee is also on the call if she has any, or if you have any questions for her.
Alex, Dale here, if I may.
Yeah.
I appreciate that it's only anecdotal, but I personally get a sense that moving TTMG physicians into the hospital was a significant paradigm shift for them that had both positives and negatives. They not having to buy their medical malpractice insurance, not have to do their scheduling, their billing, etc. But then giving up some freedom and flexibility in their work schedule. How if you agree that is perhaps one of the negatives here, how do you address that?
Yeah, we actually brought a lot of physicians onto the employment model during this time. At the same time, we're having a pandemic. So, I think that there's a lot of things that still need to be addressed. I think we're a great organization and have a lot of opportunity for improvement, as proven by the results here. And so, I really want to understand in more detail, because I think that some of the physicians that we brought into the employment model were really excited and are loving it. Some are still hesitant and maybe have some trust issues, and we have to work on those things and work on our relationships. And it's going to be, it's going to be some work that we are dedicated to doing so that we can improve these scores and certainly the relationships and overall joy in the workplace.
Okay, and one other, again, very anecdotal, may not be representative of what others feel, but I heard at least one, no, I heard 2 physicians say that our success, which is our growth, is evidenced by our growth from 47,000 patient visits now to 112,000.
Right.
Has also been somewhat of our downfall, because primary care physicians are referring to specialists and finding that they can't get their patient in for 2 or 3 months.
Yeah. That's
how do you rate that
I think it's definitely there. It's on the survey too, that they wish we had more beds available. They wish that there was more access to care, and that's stuff that we're addressing, as you know. And I think that we've had, as an organization, speaking not just for medical staff, but as an organization, we've had some growing pains. We grew really fast, and I think that across the district, we're feeling some of those growing pains, and we're trying to maneuver in a way that's still efficient and effective. And we're trying to be really cautious not to just add staff, because it's always hard to take staff away once you find out you're overstaffed, right? And so we're being cautious, and we're being thoughtful in how we move forward, so that when, as we deal with these growing pains, we're doing it the right way. And I'll say that's, to Harry's leadership, he's doing a great job in reminding us, don't just throw money at it, and it's important. It's important for sustainability. So.
Thank you.
Can I ask a question about one of the comments? If you have an understanding, it says, have more medical providers in leadership positions. They have worked in medicine and understand medical staff needs. What leadership positions are they talking about?
Well, that's one of the things we have to find out, right? And that's where the focus groups come from. And that's where that deeper, because one of the things I don't want to do is make assumptions on this survey. And so the focus groups really give us an opportunity to get in there and understand. I will say that it was unfortunate that when we designed this, we did ask for them to define leadership more clearly. And unfortunately, that did not get into the final survey. So there is some unknowns there. When we say leadership, are you talking about, basic, the management or directors of departments? Are you talking about executive team? Who are you referring to? And so that's one of the areas we still need to determine. It's unfortunate, and I will say we tried to do that prior to the survey's release, and it was unfortunate that did not get in when we finally put it out.
So I'm going to jump in here. So the other comment in the same vein was how well the respiratory illness clinic was run, what a pleasure it was. And the manager of that clinic was one of our fantastic PAs. And it was, I think, attributed to just being a medical staff member, understanding what that clinic needed, how to get it to run well. And my assumption is that's what that other comment also meant. They were different people, different comments, but that's my assumption, if you want to let me make one.
I think she's also a great leader too.
So when you have these focus groups, the focus groups will be comprised of the physicians and the PAs and NPs and.
Yeah, we'll have a mixture and probably hold several focus groups. It'll really depend, Mary, on the survey results. So we can nail down and drill down into the results a little bit deeper, so that we can identify, is there an issue in urgent care? If so, maybe we need to do one-on-one with those physicians or APPs. Maybe we can do it as a group. And that's where we really start to dive into the survey and look and figure out what's most appropriate. Should we do several at once? Should we a group together? And we'll identify those focus groups and who should attend as soon as we dive into those results.
So are these people self-identifying when they respond to the survey?
No, it's an anonymous survey, but we get to drill down into department level. As long as we had 3 or more responses, we can see individual department responses. Yeah.
So Alex, Dale here once again, and just a follow up to my question about patient referrals, concerns. I am satisfied with the ease of the scheduling process for my patients. Is that scheduling for the patient to see that physician, or again, is that a reference to referrals and the difficulty in getting their patient into a referral in a timely fashion? Do you have?
Yeah, I appreciate the question. Unfortunately, I don't want to make any assumptions until we have these focus groups, because it could mean both things. And I hate to try to give you an answer when it might be meaning something completely different. And that's why it's so important. Even with the employee engagement survey, these focus groups really tell us a lot. And we can ask very specific questions. We can even bring this comment and say, hey, this is the comment. Tell me what you think this meant. Was it talking about, the access center and our patients aren't scheduling, or are we talking about, I don't have the availability what exactly are we talking about? And so that's where they're really, really helpful.
Yeah, okay.
And Alex, will we be getting any kind of progress report once these focus groups have met, or?
I'm happy to do that if that's what you all request. Happy to do that for sure. I just want to close with saying, you know, all organizations have ups and downs, and this is, you know, these results, although not maybe where we want them exactly, it's still important that we own this. Like, this is where we're at, and we have work to do, and that's okay. We have a great culture. We, you know, again, we're nominated for best place to work, and we don't take that, yes, we have a great culture and that we're nominated for these other awards without recognizing that we have to continually, constantly monitor and improve so that we can remain in these high levels of culture and best places to work.
Alex, one last question, if I may. We all read in the news about physician burnout and the tremendous stresses that COVID have put on physicians. When we are comparing our scores with national averages, are we comparing apples with apples, or are we comparing our scores with older national scores that were pre-COVID?
Shawnee, do you remember the alignment, the resilience and the scores from the 21 and 22? I don't have that in front of me.
Well, what I can tell you, Dale, is when we originally, so we did our survey in November of 2021. And because of that, when Press Ganey gave us our original scores in the end of December, they compared us to calendar year 2019 and calendar year 2020, which is what Alex was alluding to earlier, that I pushed this January to get me updated numbers. I wanted them to compare our November of 2021 data to their 2020 and 2021 data, because that is more similar to our results since we did it at the very end of the calendar year. So unfortunately, I literally just got some of these results yesterday. I asked for an updated executive overview report. I only got 2 slides, which Alex was able to so quickly put into his presentation tonight. So thank you, Alex, for doing that. But I'm waiting for the other slides to compare us to a better time frame. I think that, you know, our doctors are looking back at how they felt over 2020 and 2021. And now we're going to have that data on how the other physicians felt in those 2 years also.
Okay.
Harry?
A couple clarifying questions.
Go ahead.
Oh, sorry to step over there, Harry.
You can go ahead.
Yeah, just a couple of clarifying questions. I apologize, I always geek out on data. And Alex, I hear you loud and clear. You don't want to read too much into some of these things. But first off, 78% response rate. Congratulations there. I mean, that's insanely high. But it also represents a 30% increase over 2019. So, I mean, is there a chance we're just seeing, you know, there's differences just because of the sample, the population? We're getting more answers. Would be the first question. And then 2, so is it just physicians, or because the title is medical staff engagement, so would this reflect nurse response as well, as is just physician?
Just physicians and advanced practice providers. So nurse practitioners and physician assistants.
So the way I, again, globally interpret, when I look at the strengths, they actually reflect, there might be some response bias. The strengths really seem to be strong for the things that physicians might have control over. Hospital provides high quality care. You know, I could see physicians rating that high. It would reflect on their care. And concerns really seem to be around maybe the way I'm being recognized, or things that leadership would have control over. So I see just a little bit of tension then between perhaps physician and leadership. Leadership was the lowest score at 3.53. So that's an area that I'd love to get, you know, in the focus groups and whatnot, sort of that understanding of, you know, is there some tension between leadership and physicians, which there always is to some degree, but you know, is that an area of focus?
Yeah, that absolutely is. And if we had all the data, I would pull up the alignment, and we can see clearly that there is some concerns on the alignment, right? And how so we got 0.44 below the national average under alignment. And we didn't. This isn't a surprise to us, and even without COVID, it's not a surprise to us because lots of changes came for these physicians since 2019, including the employment model. And so there's inherently going to be some of that. Now, I can't say where we should have been, but I can say we are where we are now, and we've got the data, and we're excited to start working on better alignment, and making sure that physicians and administration are aligned, and further the directors and the managers and even the leads in their clinics. And I think that it's an opportunity for us to enhance in all of those areas, both with education and with just frankly trust, and trusting that we all are working towards the same mission. Carrie,
So, Director McGarry, I just wanted to go back to your 78% response rate there. The average for the Press Ganey is 50%. So I think that what that tells you is the medical staff members, they are engaged. They want you to know what's going on. They want their opinion heard and everything. And so I think that's great. And I think we need to respect that they are here to serve our community, to do the awesome high quality work that we know is happening in the hospital.
And I think that, you've presented the results, and it's now time for the medical staff to take a look at them all and come up with their focus groups to talk about how they can improve or clarify or do whatever they need to do with that. So I want to turn that engagement survey back to HR and the physicians and have you work on that and let us know how the update goes.
Absolutely.
So
and just as a reminder, and I know Harry had a couple of comments, but just as a reminder, we are building some strategies in the strategic plan to address this as well.
Harry, did you want to make a last comment?
Yeah, just briefly. No, it is very important to us. This is the first facility that we've done a Press Ganey survey every single year. And I think it just shows how much we care about each of our audiences, and we do act on those. And as I talk to other CEO colleagues out there, we're clearly doing a lot more things, but that's never good enough. We want to hear what things our team can share that fit in the context of best practice quality, patient satisfaction, and business efficiency. And those are things that very likely we can do. One of the top 3 dissatisfiers that caused physicians to leave private practice was changing regulations that they couldn't handle, or the significant drop in pay or EMR, work-life balance. Those were some big issues that caused providers to move into a corporate environment. The other thing that we really want to move the needle on is, as we're looking at a lot of friendly advice, whether it's this 3 Good Things app, is when you look at things on an 80-20 basis, we want our providers and all of our members to find that persuasive zone where we can experience joy and gratitude every day. What are the things that we can control? What are the things that we can't control? So that we do have great joy in our lives, and the organization is listening, helping, and it's doing tuning processes as well. So we know that it's going to take a personal improvement journey for our team members and us tweaking our processes as well. And we're trying to do both, which is really rare at this stage.
So if there's no further discussion, we'll look forward to hearing more about that focus group and what they're doing. So moving on to 15.4, our COVID update. And Judy Newland, are you going to give us that?
I am. I'm going to let Harry start.
Okay.
Sure. Good evening, Chair, members of the board. I think this is an exceptional day. You've heard me say that before, because for sure we're one day and maybe many months closer to getting towards the end of this pandemic, where it could be an endemic. and hopefully a weak endemic. And I'm going to give you just a little bit of brief data through the first 22 months, and this would be like from March of 20 through 12/31/21, our 3-county region had 4,691 positive lab tests just in the first 27 days, not even a month out of the 22 months so like in month 23, not quite even a full month, we had 2,499 additional tests. That's a 53% increase in 1 month as compared to 22 months. So if that isn't an explosion, and when you look at these kind of things, you do want an explosion, and preferably an explosion. It's a very friendly, contagious disease, but you'd like to see it with lower acuity. And I think we are seeing that, and you really need that to see these kinds of viruses slow down. So I think it may be scary, but I think it's also really exciting to see. As I look at all of those intense periods over the last 23 months, they lasted about 8 to 9 weeks. And even around the world, there's some pretty clear reports that Omicron, for example, is also about 8 weeks. So I think it'll be very edifying come around February 25, March 1, as to what are all the variables that are important to us at roughly a 23-month interval on the pandemic. So I'm excited that the acuity level is way down, and I think we really needed, as much as it's scary to say for some, we needed this explosive trend. It's very friendly to kind of settle things down for the longer term. Again, there's a lot we're still learning about it. Like, we can't ever certify are there going to be other variants. There may be, but it is nice to see this change. And I'll stop there and let Judy share some other important details.
Thank you, Harry, Board of Directors. So I want to start by reminding everybody that I know we see routinely recommendations from the CDC. And we do routinely get a call like, well, why aren't you doing this? The CDC said this. So let me explain what happens in the state of California. If it's a vaccine, and the CDC has a recommendation, it actually goes to a Western Scientific Safety Review, which represents 5 states. And that once they approve, then it goes to CDPH. Or everything CDC does, the CDPH approves it and then sends it to hospitals. So sometimes you will have a delay. And so we don't, just because the CDC does it, doesn't mean that we're going to implement it. We wait for the CDPH. So currently we have 5 patients in the hospital, and I learned from our public health officer this week that in the state of California, and it's true for our patients, about 50% of the data that you hear about admissions, 50% are actually patients that had symptoms that got admitted to the hospital for COVID. The other 50% are patients that got admitted for a different diagnosis, and because we test everybody, they're positive. And that is still true at Tahoe Forest Hospital. That was interesting information I learned. Currently today, we have 60 employees out, 32 are COVID positive. Now, about 2 weeks ago, we had about 140 employees out and 103 positive. And that's why the resolution, I just have to tell you, I think the resolution is so meaningful, because we did not, as a health system, stop any services. And that happened because of the staff. We had staff working in other departments that had never worked there before, but they were willing to help. We had physicians working day after day to care for the patients. And I'm just telling you all, it speaks to who we are. It is so impressive with all those employees and physicians out that we continue to provide services. In the state of California today, we have an 18.8% positivity rate. Nevada County is at 27.5 today. So the county health officer has felt that really we are still surging in the county of Nevada. So we are seeing less positive employees, but I think we still need to be cautious on the east side. And our testing at our hospital still showing a high rate. Placer County has a 24% positivity rate, and Washoe County is up to 30%. They sort of started later than Nevada and Placer County, just so you all know. When we were at 18%, I think they were still at 10. So they've sort of gone up pretty fast. So for our testing at Tahoe Forest Hospital and in Incline, so we, as you know, test only symptomatic. So we are still seeing anywhere from a 30 to 39% positivity rate for Truckee, and then Incline is about a 40% positivity rate. But again, everybody that comes here is symptomatic. The other day we were down to 29. I didn't know what we have today. So we're hoping to see a decline, but we still seem to have a pretty high positivity rate. Our respiratory illness clinic luckily is down to just about 200 calls a day. They were up to 500 calls a day, but down to 200. Are testing pretty high, about 100 plus per day. And our Incline Village Community Hospital also is testing about 15 a day in an hour. So still very busy with testing. As you know, we had a mandate for the state of California that required all hospitals for anybody that is booster eligible, to either receive a booster or to have documentation for an exemption, either religious or medical. We started with 500 employees and we are down to 80. The state of California did extend the deadline for meeting that compliance. It originally was February 1st, and yesterday I think they extended it to March 1st. So we are testing approximately currently between about 80 employees. Starting next week, we're offering that testing 7 days a week, an hour a day over at our respiratory illness clinic. So thankful for occupational health and our respiratory illness clinic staff who will be doing that testing. And also we offer it over at the Pioneer Center, and we also offer it at Incline. So trying to make it as available as we can for our staff. Just a reminder, our vaccine clinic continues. We do Thursday, Friday, Saturday, Sunday. And again, we really made that change because of parking. We used to do Monday through Friday, but when we started doing the pediatric population, we knew we would have an increase in volume and wanted to make sure that everyone could park there. So we are doing Thursday, Friday, Saturday, Sunday, and that seems to work fairly well. Just a reminder that 18 and over can receive J&J, Pfizer, or Moderna, and 12 and over is a Pfizer, and they now can receive a booster, and then 5 to 11-year-old is Pfizer. We are preparing in case vaccines become available for the 4-month to 5-year, what that process would be for our community and our health system. We still have community testing. So LHI, which is provided by Placer County on Donner Pass Road, they do asymptomatic and symptomatic. Unfortunately, they got their supplies sort of decreased. They used to be able to take walk-in. They have not been able to take walk-in. So they used to do 500 a day, 400 scheduled, 100 walk-in. So that has been put an extra pressure on our testing, and I haven't heard back when they'll be able to do walk-in. And then again, for Tahoe Forest Hospital, we provide symptomatic testing, and Incline also provides symptomatic testing. So just again, briefly then on treatments. So we currently have received this week some of the oral treatments. So that's the Placovid and the it's called Monopiravir. So we have received some doses of that. We received doses based on allotment from the county. And so unfortunately, we live in a county that's not highly populated. So what is currently happening is we are receiving 1 week of the oral dose, and then the west side is receiving the oral dose the next week. So this week we do have it, and our retail pharmacy has it available, and our physicians through Dr. Cole have all been educated and understand those who qualify. But anybody that comes with a prescription, and by the way, it doesn't matter where you come from. You can come from Illinois, fly here, and still get, you have to fill any prescription that walks through the door. And we also still have available, well, we can do infusion, which is the Sotrovimab, which is for Omicron. And again, that is limited. It's depending on, again, given to us based on our population. So we still are providing monoclonal therapy when we have that available to us. So I just really a shout out to our medical staff and our clinical team that really manages that treatment. I think they've done a really good job. But again, luckily this week we do have that oral medication available. And Washoe County and Incline, currently those pharmacies do not have it available, but we are going to work with Washoe County to see if they'll be getting any of those oral medications. That is my report. And Dr. Cole, I didn't prepare her for this, but I wanted to know if there was anything that you wanted to add. We sort of tag teamed this quite a bit recently. So is there anything?
I want to give a shout out to Tina Mather and Megan Shirley again for the educational session that they did give the medical staff just last night regarding all the oral antiviral medications. And also a big shout out to Dr. Sutton Pato, who is one of our medical staff members, but who is also the county health, I don't know what her exact title is, in Sierra County. And because we service so many of the Sierra County patients, they actually allotted their oral antivirals to our health system to distribute. So that was a big win for our community, a big win that we'll be able to help their community by being able to distribute these medications. So thanks so much for such a complete report, Judy.
And I wanted to add a shout out to our OC Health staff, but interesting enough, when we started the testing, which we're doing the antigen testing for anybody who was booster eligible, it was really, to our surprise, like the first day, I think we tested 10 people and 3 were positive. So the first 3 to 4 days, we actually had a 10% positivity rate for asymptomatic employees. So that was really interesting. Now most of them are negative because we weeded all of that out. But anyway, and the other thing that, just so you know, the other thing for our positive employees, we are finding the employees are positive from outside the hospital. So I want everyone to understand that. Mm-hmm. So it's really, it was the holidays, it was family, it was children, it was best friends or family that created the positivity. We are not finding, again, mass to mass, that we are seeing any positive employees. So I did want to share that. Thank you.
Okay.
Fine.
Any questions?
Oh, thank you for the update.
Yeah.
I guess the one question I have is, it seems like the masks are still effective for our personal protection.
They are. And I think, you know, it's interesting in our, well, I think if you look at the information, yes, masks are still important to wear, both parties.
Judy, Dale here. I did read recently, and I wonder if you can confirm this, that it's likely we will get another variant, but that each variant will be weaker as we go forward. Is that information correct? Is it generally known? I just wondered.
Well, I'd actually would steer to Dr. Cole if she wanted to respond to that. I mean, we hear different things. Shawnee, would you like to respond to that?
Different things.
Yeah, so typically when a variant changes, it either becomes more contagious or it becomes less contagious but more virulent. So Omicron we found was way more contagious, less virulent,
right,
more mild disease. So honestly, we don't know what the next variant will take, which way it will go.
Okay.
May I add something, Alice, while we're talking about this and giving shout outs to everybody? I mean, I think we have to give a shout out to everybody who's on the screen. I mean, the leadership that has been provided by all of you has been remarkable, and it has allowed, you know, everyone else to do the work that, the fabulous work that they've done also. So shout out to every one of you, Harry.
Connection.
Yeah.
Yeah, and thanks, Judy, for being our incident commander through this whole thing.
It's been a team effort. It is a family, that is for sure.
Yep.
Well, it's been remarkable.
Again, I go back to when we had all of those employees that I had somebody from the foundation who went over and helped in the respiratory illness clinic. I had a nurse from over here that it was the quality department. Everybody just jumped in and understand the priorities was to keep the services going and to help each other. It was really impressive. And the medical staff also.
Wow.
I've tried to help by not coming to visit.
Also, it speaks to the culture that's been created that exists there. And I just think it's remarkable.
Yeah, second that.
Well, as Harry and Judy know, I contracted the bug on January 3rd and got over it fairly quickly. My wife kept me locked upstairs for 5 straight days. She had me on a strict diet of pancakes and flounders. That didn't do anything for my health. It was just the only thing she could slip under the door. Yeah.
And I think the other thing, I just want to remind everybody, the opportunity to order your own antigen tests. If you recall, the White House opened that door. I think they had so many millions, 500 millions, that individuals, you could go online and order your own for your family and receive 4 for free.
They're supposed to start tomorrow, aren't they?
I already got mine. It came like in 2 days, but they're not free. We paid for them.
Well, thank you, Jake. That's true.
Yeah.
You can go online and order them now.
Yeah.
And I think only 50 million have been ordered so far. So.
Well, great.
Thank you.
So, thanks, Judy, for that report. And I have to apologize. I keep losing connection. I also lose my papers, but we didn't pull anything from our consent agenda, so we can move on now to any committee reports. So I know that governance committee met this month, and pretty much our focus was on the board self-assessment, and we scored about the same, but there were some issues that we came up with that we'll be addressing at our retreat this month. So you'll hear more about those results, and I think you'll get a summary of what the results have been for further discussion at our retreat. And then we also looked at our charter. We did some editing, making it more of a useful document and not constricting us to certain dates to have things done by. And then looking at our plan of education for the board. And we will be asking our board members to provide us for some information at our retreat on that. Any other committees? And the task force for strategic planning also met, and Mary and I are on that committee. And you'll be getting a summary of what the results are, but pretty much we defined or refined the mission, vision, and value statements. Also the board's statement on it. And the AC is going to continue to work on the metrics for the objectives that have been established. So again, you'll get information on that, and then we'll be discussing it further at our retreat.
Just quick up, the House of Foundation met. I think some great updates came out of there. Largest end of year appeal at $207,000, and they were able to use a grateful patient data to reach more people. So great year end push there. Outside of that number, there were two $100,000 gifts that are pending. They're coming in, I believe, in February. Both of those were for appreciation of care, which just speaks volumes to me, right? Somebody comes in, gets great care, and is like, "Hey, my hospital bill wasn't big enough. I'm going to throw another $100,000 at you." I mean, obviously, just speaks to the quality of care that people are getting. One was for cardiology, one was for cancer. With those, we're on track to exceed the total prior year funds by the end of January. So, like 5 months earlier than we did last year. There'll be a draft stewardship report. There was a draft stewardship report presented. That'll be going out to the community sometime in February, which just basically highlights the work of the foundation. And then finally, we approved funds for the VELUS robotic assisted knee replacement, which was, I think, in total $537,000. So a great piece of equipment for the hospital there that was approved by the foundation. And I think those are the highlights.
Any other reports? Any last comment
I have a comment.
before we adjourn?
I do want to, there has been some instances of people spoofing board members' names. They can't spoof their email address, but they have been spoofing their names and trying to get people to buy gift cards and take pictures of the gift cards and send them the pictures of the gift cards so they can go redeem them. So if you get an email that's not from our domain, tfhd.com, there'll be a big red header that says this is not from our domain. So be careful looking at it. I would suggest if you're going to email each other, don't do it more than 2 people at a time, and use your TFA. I see you giving it a thumbs up there, General Counsel. But use your TFHD account so we can shut that stuff down pretty quickly. But if you do have that, let me know quickly and I can get it shut down.
And send you the gift cards, right?
I don't need any more gift cards. I appreciate the thought.
Yeah.
Yeah, thank you so much for bringing that up, Jake. Because that has been going around, and apparently because we have public email addresses, that it's very easy to get a hold of us or get a hold of our emails. And the fact that they were able to identify me as the chair was really remarkable to me. So again, be very cautious about those emails.
If you were really in Hawaii too, I was going to be worried. I was like, they're spying on me.
Unfortunately, I got no gift cards. Okay, if there's no further last comments, then the meeting is adjourned. Thank you again.
Thanks, everybody.
Thanks, everyone. Have a good evening.
Thank you. Bye.